Hi, everyone. So in this session, we're going to review an abstract that is for a retrospective study of serial polysomnograms of bronchopulmonary dysplasia patients with oxygen dependency prior to the age of 1. My name is Dina Yusuf. I am a pediatric pulmonology fellow at Children's Hospital Los Angeles in California. So a little bit of a background. So bronchopulmonary dysplasia is a multifactorial pulmonary disease, and it's a disease primarily affecting premature neonates, although it can affect older newborns. There's often a history of mechanical ventilation and long-term respiratory support needs, such as supplemental oxygen. And nutritional status and growth plays a huge part in the development of these patients with bronchopulmonary dysplasia, and it ultimately affects their long-term outcomes. Bulk of the outcomes that are periodically assessed involve neurodevelopmental factors. And so a lot of times these patients really do deserve a multidisciplinary approach, an interdisciplinary approach when taking care of them in specialty centers. So there are multiple prenatal factors that affect BPD severity. Again, the type, the duration, the chronicity of mechanical ventilation, frequency and severity of infections play a role. Growth arrest as a result of early premature birth is often a very huge contributory factor. Genetic predisposition also plays a role, and all of this ultimately defines a certain phenotype of bronchopulmonary dysplasia patient. There's impaired alveolarization and vascularization, leading to abnormal repair and remodeling. High pressure mechanical ventilation and high amounts of supplemental oxygen with regards to FiO2 requirements often lead to oxidative toxicity, and it's believed to drive a kind of a local ongoing inflammatory process at the alveolar level. Airway malacia is a contributor as well, and may contribute to prolonged respiratory needs. So for the sake of this study, we classified patients per the criteria set by the NHLBI 2000 workshop, primarily saying that these patients fall under the mild, moderate, severe BPD categories. And so the assessment is done at a defined time point assessment. And so if the child is born less than 32 weeks, then we assess at 36 weeks postmenstrual age or at discharge. If the child is over 32 weeks, then the assessment is done if the child has been on oxygen or has been over, as far as age goes, over 28 days, but less than 56 days postnatal age, or at discharge, whichever comes first. And so the categories, again, are mild, moderate, and severe. A child who's less than 32 weeks of age or born at less than 32 weeks of gestational age falls under the mild category if there's oxygen used for over 28 days, but at the time point assessment, the child has been breathing room air. It's moderate if there's oxygen used for over 28 days, but the FiO2 requirement was less than 30% at the particular time point assessment. It is severe if the oxygen use has been for over 28 days, but the need for FiO2 has been more than 30% at the time point assessment. For a child who's over 32 weeks gestational age, he or she falls under the mild category if oxygen use was over 28 days, but breathing room air by 56 days postnatal age. It's moderate if oxygen is used for over 28 days, but the need for supplemental oxygen with FiO2 less than 30% is by 56 days postnatal age. And severe category is if oxygen is used for over 28 days, but the need for FiO2 of over 30% by the time the child is 56 days postnatal age. And so what kind of sparked this study is that we often find at the very first pulmonary clinic visit, parents and mothers always ask, when will my child come off of oxygen? And are you the doctor who will tell me when my child will stop needing oxygen? And it was a particularly difficult question to ask simply because we don't have much data to try to prognosticate or kind of give an accurate, even an estimate. And so this was how this study pretty much developed. Many patients at Children's Hospital Los Angeles receive polysomnography that is done to assess gas exchange and determine supplemental oxygen needs. Polysomnography has been used in other institutions to assess readiness for tracheostomy decannulation, for example. And Sharon et al. Reviewed actually preterm patients with chronic lung disease polysomnographies between 2008 2012, and they looked at 60 patients from the Johns Hopkins registry, and they described a mean RDI of 8.2, a mean oxygen saturation nadir of 86.2. Again, more than one polysomnogram was done in 23 patients, most notable with a decrease in RDI between the first and the second sleep study. And so they concluded that mean RDI is higher in chronic lung disease compared to control that was previously published, but the RDI decreases with age, suggesting an improvement in pulmonary reserve, which is quite reassuring. Overnight polysomnography is more sensitive in assessing pulmonary reserve than outpatient clinical measures. And so we aimed essentially to show that serial polysomnography often offers a non-invasive modality to assess ongoing oxygen needs and provide an insight into other possible pathophysiological issues such as obstructive sleep apnea and central sleep apneas, baseline oxygenation, et cetera, that can change over time as a result of growth and lung development. So for the methods of this study, so we looked at all polysomnograms that were done in 2016 with patients born premature, less than 32 weeks gestation, with BPD and meeting the criteria that we described earlier for BPD. We included patients who had at least 2 polysomnograms, consecutive polysomnograms, and we excluded patients who had polysomnograms kind of late in their in age. So over 1 year of age essentially was our cutoff. This was again a retrospective study. We used Stata 13.1 for our data analysis, and we aim to essentially compare also the first sleep study parameters in patients who were weaned to room air after this second sleep study. And again, the results are still pending for that. So that's part of the study that's in progress currently. And so in total, we looked at 88 polysomnograms and we reviewed 44 patients in their data, including gathering clinical information. We found that 68% were males. The median gestational age was 26 weeks with an interquartile range of 24.6 to 28.1 weeks. 77% of our cohort was actually severe BPD. So we were dealing with a much sicker population at our institution. And the median birth weight was 777.5 grams with an interquartile range of 632.5 to 1,054 grams at the time of birth. So looking at this kind of result table, a few things stood out that became apparently statistically significant. There was improvement in obstructive sleep apnea, primarily characterized by obstructive apnea hypopnea index with age. There was improvement in obstructive apnea index as well. There was improvement in mixed apnea index. There was improvement in baseline oxygenation and nadir oxygen saturation. There was resolution of tachypnea with time. There was improvement in heart rate. There was reduced arousal index, so patients essentially woke up less frequently from sleep over time. There was improvement in sleep efficiency. And there was improvement in peak and tidal CO2. So in conclusion, we thought that patients with BPD have an abnormal polysomnogram parameters to start with, and indices that are indicative of need for supplemental oxygen, predictably much longer. These parameters, however, tend to improve over time, suggestive of central nervous system maturation and parenchymal airway growth and improvement in pulmonary reserve overall. Polysomnography provides actually a useful non-invasive surveillance method and typically show improvement over time overall in patients with BPD, including the severe category. And patients who fail to improve or show improvement in serial polysomnography during infancy, they should undergo further workup for other comorbidities and or diseases, as this will be a bit atypical for a BPD course. However, future studies are needed. There's need for correlation between neonatal clinical factors and severity of BPD, in addition to how this impacts polysomnography findings, particularly over time. Future polysomnograms can actually be designed as diagnostic studies to follow changes in serial studies and explore its association with BPD severity further. Association with duration of oxygen need is currently being investigated as a second phase of this study. These are my references. Thank you so much for listening.